Crushed metacarpals, or commonly known as boxer's fracture. This involves the metacarpals of the hands. The metacarpals are the bones of the hands that connect the phalanges or the finger bones to the carpals or the wrist bones. The ligaments involved in this injury is the palmar aponeurosis, and the muscles involved are the palmaris brevis, opponens pollicis, abductor pollicis brevis, flexor pollicis brevis, opponens digiti minimi, which rotates the metacarpal of the little finger towards the palm, and the abductor digiti minimi, which abducts the little finger. The common causes of this injury are sports movements such as boxing, and other causes may be due to high impact injury such as mislanding during a fall or a carpenter mistakenly hitting his hand instead of the nail. Common symptoms of this injury are pain, swelling, bruising, limitation of movement, deformity such as knuckle asymmetry, or the knuckle may appear to be missing, and finger misalignment may also be noted. Doctors diagnose this injury by physical examination of a suspected metacarpal fracture, should concentrate on hand deformity, tenderness, digit malrotation, and presence of open wounds. Radiographs or X-rays may include three views: anterior-posterior, lateral, and oblique, to assess the fracture. Ultrasounds may also be done to further assess the fractures, and other techniques such as bone scintigraphy and MRI, although an MRI is almost never necessary for an isolated metacarpal fracture, as they normally give the same information as an X-ray. Initial treatment of metacarpal fracture involves splinting of the hand to prevent further movements and further injury. It is also advised to raise the hand higher than the heart level to prevent further swelling. Further treatment of metacarpal fracture may involve surgical, where operative stabilization is necessary for metacarpal fractures where there is too much bending or displacement at the fracture site. Surgery is often required to clean out the wound to decrease the chance of an infection, and surgeries may involve wires or splints to hold the bones together. Non-surgical treatments may include immobilization of the patient's hand with a splint, a cast, or sometimes a removable splint as it heals. Recovery takes 6 to 8 weeks. After 3 weeks, the cast may be changed to a removable splint. In cases of surgical treatments, recovery may take up to a few months or a year. X-rays are checked every few weeks to be sure the fracture is healing properly and the bone ends maintain their alignment. The return of athletes to their sports may depend on the development of their physiotherapy. Physiotherapy and may involve edema control or the swelling of the involved body part, and hand exercises. Hand exercises such as tennis ball exercise can be done by holding a tennis ball and gradually squeezing it as hard as possible for 3 seconds and repeating it 12 times daily. Wrist bends may also be done by putting your forearm on a flat surface such as a table or a bench with your wrists on the edge of the table. Bend the wrist up and down slowly as far as possible without pain. Repeat 12 times daily. Hand open and close exercises may also be done. Clench your hand on a tight fist and then open up, straightening your fingers as far as possible without pain. Repeat this exercise 12 times daily. Finger abduction and adduction may also be done. Begin by putting your palms open and the fingers close together, as seen in the first picture. Then gradually spread the fingers as far apart from each other as possible without feeling any pain. Repeat 12 times daily. And these are the references to my presentation.